I'm Jack Woodside. I was faculty here ages ago. I'm going to talk about opiate use disorder. That's what OUD is. And I've got a lot of material. This is actually 2 talks, so I'm going to go fairly fast and also skip over some stuff. So if there's parts of it and I also want to leave 10 or 15 minutes at the end for questions and discussion. So if there's something that you'd like to hear more about, just keep it in mind and we can talk about it at the end. First of all, I want to start, I have no financial interest. And I may discuss unapproved uses. Now, medication-assisted treatment, today when people talk about it, they think of Suboxone, buprenorphine, but in fact, medication-assisted treatment for addiction covers a lot of territory. Anabuse, disulfiram has been around for alcohol dependence for quite a time. Naltrexone is being used for alcohol dependence, and then there's also this other drug, acamprosate, that's available as well. And naltrexone and acamprosate improve outcome for people with alcohol problems. And there's also medications for nicotine dependence, so nicotine replacement, gums, patches, lozenges, nasal sprays, inhalers. You all know that bupropion is helpful in nicotine dependence. And then there's Chantix, varenicline, that's also useful. So really, when you hear about medication-assisted treatment, it involves a lot more than just simply Suboxone. And for opiate use disorder, there's in fact 3 medications: methadone, which you know about, buprenorphine, which you've heard about, and also naltrexone is helpful in that situation too. So I'm going to talk a little bit about how we got to where we are today. This is Mrs. Winslow's soothing syrup for children teething. And what you didn't know if you got this was that it had morphine in it, okay? So after a while, and it's also not clear to me whether this soothes the baby that's teething or the mother that's having to listen to it. And my guess is that probably both of them ended up getting it. And after a while, you just found that life wasn't the same without Mrs. Winslow's. And without knowing there was morphine in it, you really wouldn't know why. So as a result, and addiction was becoming a big problem in the late 1800s. Part of it was because cocaine became available, was discovered. Purified opiates were appearing on the scene where it used to be opium and its derivatives, and also hypodermic needles became prevalent during the Civil War. So by the end of the 1800s, there were lots of people that were addicted to addicting drugs in one way or another. So in 1906, Pure Food and Drug Act required that there be on the label telling you what was actually in the substance. And they specifically mentioned 10 addictive ingredients. These are 8 of them. And then there were 2 others that I had never heard of that apparently have passed by the way. And as a result of this, the Food and Drug Administration came into being. But that really didn't end the problem, because now, although it was labeled, if in fact you were addicted to the substance, now you knew what you wanted to buy and what you shouldn't waste your money on. Cocaine toothache drops. So the next step in this was the Harrison Narcotic Tax Act in 1914. And it was popularized with a lot of immigrant fear, which is kind of reminiscent of today. They talked about opium was associated with Chinese, marijuana with Mexicans, and this was actually a title in the New York Times in 1914, which is kind of incredible. Now it was a tax act, so that if you imported, distributed, or sold these substances, you had to apply for a license to the Treasury Department and pay a tax on it. So that allowed the government to control the traffic in these drugs. And physicians were exempted. And the phrase was, in the course of his professional practice only. However, this was the Treasury Department. These were law enforcement officials. So what had originally been a public health measure turned into a law enforcement issue. And in 1917, they were interpreting that giving addicting drugs to someone known to be addicted was not part of professional practice. And so they started arresting doctors, imprisoning doctors, big fines, and it went all the way to the Supreme Court in 1919 that upheld that interpretation. Now, up until that time, there had been morphine maintenance clinics for opiate addicts, and that ended really quickly. Putting doctors in prison and big fines caught the attention. But also what's important, it was at this point that addiction became illegal. And prior to that, although it was a big problem, you didn't get arrested and put in jail for it. So, medication-assisted treatment for opiates. Methadone's been around for a long time. Methadone was the first exception to that Harrison Narcotic Act. And in the late 60s, early 70s, it was allowed to be dispensed to somebody who's opiate addicted, but only a program was certified by the government to do it. Physicians weren't. Methadone clinics were. And they were only certified to dispense methadone. They couldn't prescribe it. Methadone was picked because it's long-acting. As you know, it's an opiate, and it's also used for chronic pain. It can be used for opiate detoxification or for opiate substitution therapy. And actually, the newer term now is opiate agonist therapy or methadone maintenance. It's usually dispensed at methadone clinics as a liquid so that it can't be diverted. You can't like spit the pill out and take it out and sell it. And you drink the liquid under direct observation. So initially you have to go to the clinic every day, which is an issue. For the time we didn't have a methadone clinic in Johnson City, people were driving to Boone or to Asheville because those were the closest clinics. After a while, if you're stable and gain some credibility, you can have take-home doses, for example, the weekend, or if you're going out of town. And essentially, methadone maintenance can continue for months or even years. There's a guy in New York City that has a group of people that have been on methadone maintenance for 30 and 40 years. And he's a big advocate. He says these people are doing well and have had careers, and many of them are professional people. Now, there are clear benefits to methadone maintenance, and most of these studies came out of the 70s when it was still a new thing. It just decreases illicit opiate use by 75%. Acquisitive crime is crime committed to get money to buy heroin or other illicit drugs. That drops by 60%. People get back to work or back to school, social function. This is big, reduces mortality, and people on methadone maintenance have mortality rates that are similar to the general population. And then more recently for HIV, prevalence is 18% in those on methadone maintenance, whereas 39% in people that are active opiate addicts. So it's overall improved quality of life. Now, the next exception to the Harrison Narcotic Act occurred in 2000 with the Drug Abuse Treatment Act. And it allowed physicians to treat addiction with opioids. It had to be a Schedule III opiate, and it had to have a specific FDA indication for the treatment of opiate use disorder. The law has been expanded and modified, and now it allows physicians, nurse practitioners, physician's assistants to apply to the DEA and get a waiver that allows you to prescribe buprenorphine for addiction. You can do that if you're certified by any of these bodies. This is American Society of Addiction Medicine, and that was my certification. This is American Academy of Addiction Psychiatry, American Board of Addiction Medicine. And as of this year, the American Board of Preventive Medicine offers a certificate in addiction medicine. And this is the first ABMS recognized board, other than the psychiatry certificate. Or if you don't have one of these certifications, you can take an 8-hour CME course that also will allow you to apply for the waiver. Now, initially, the law limited you to 30 patients. And the reason for this is their vision initially was that physicians would make this part of their regular medical practice, okay? And they didn't want it to turn into methadone clinics, because the methadone clinics had become big money-making schemes where they'd have several hundred patients that would pay $10 to $15 a day for methadone that costs pennies. So by limiting it to 30, they thought, well, that won't happen. Well, as things have worked out, most of the buprenorphine is coming from Suboxone clinics, which for all intents and purposes look a lot like the methadone clinics. So later on, they allowed it to increase to 100 patients. And at this point, it becomes profitable. Most of the Suboxone clinics charge $100 cash, won't take insurance, expect people to come every week. And so if you do 52 weeks at $100 a week, that's $5,000. And if you've got 100 patients, that's grossing $500,000. So that's why you see lots of Suboxone clinics around. But the idea was that physicians like you guys would do this as part of your general medical practice. So patients, if a patient goes to a methadone clinic and somebody sees you there, oftentimes they're in kind of scuzzy parts of town. But if someone sees you there, they know why you're there if they see your car in the parking lot. And the idea was that you could come to an office like this, you'd sit in the waiting room, nobody would know why you were there, it was more discreet. But that's not the way things have actually worked out. Now, the only drug at the moment, Schedule III opiate, that has an indication is buprenorphine. It's a Schedule III. It also has a long half-life like methadone, which allows it to be dosed daily. It is a partial opiate agonist at the mu receptor, which means there is a limit to its effect. It also limits its overdose risk. But if you combine buprenorphine with other sedatives, alcohol, benzodiazepines, or other sedative hypnotics, the overdose risk goes up. And in fact, prescription of buprenorphine, and actually all opiates with benzodiazepines now, has a black box warning from the FDA. There was a letter that came out earlier looking at Tennessee data from 2016. There were 67 overdoses that involved buprenorphine. Only 10 of them were buprenorphine alone. The rest of them were buprenorphine combined with another sedative. And in fact, the one we had in this area, the health department tells me that the individual was somebody with severe COPD who just couldn't tolerate even the limited amount of respiratory depression. And this, you all know this. This is just opiate receptors, full agonists will bind it and activate it. Naloxone or naltrexone bind it but don't activate it. And buprenorphine is somewhere in the middle. It binds it, but only partially activates it. Which also means that with increasing doses of naloxone, you don't get any opiate effect. With a full agonist, of course, increasing the dose, you get increasing effect. And what happens with buprenorphine, somewhere around 30 milligrams, it plateaus off, where increasing doses don't give you any more effect. And this plateau, for most people, is below the lethal level. So it's hard to overdose on buprenorphine. The other thing characteristic of buprenorphine that's interesting is that it has a high affinity for the mu opiate receptor, which means it will displace pure opiate agonists. So if you have somebody that's using OxyContin and they still have oxycodone in their system, giving them buprenorphine could precipitate withdrawal, because it'll displace the oxycodone from the receptors, but only partially activate those receptors. And so the net opiate effect actually can go down if you add buprenorphine. So patients have to be free of agonists before you can start buprenorphine. And for the short-acting drugs like hydrocodone, oxycodone, heroin, 24 hours is plenty enough time. For the long-acting drugs, transitioning somebody from methadone to buprenorphine is a little trickier. It takes probably 3 days before you can start it. The drug has poor GI bioavailability. It's been around, buprenorphine's been around for a long time, but it was limited as an injectable that was used in the hospital for analgesia. And that means it doesn't work as a tablet. So the formulations that patients use now are sublingual formulations, mucosal absorption in the mouth. And it is an opiate, okay? And it has opiate effects. It has an abuse liability. There's a lot of buprenorphine that's diverted, and that has given it a bad name in the law enforcement community. Most of the buprenorphine that's on the street is bought by people trying to control their opiate withdrawal. Although there are some people for whom buprenorphine is simply a drug of abuse. And I've met one person that it was their first and only opiate they've ever used, so it's their drug of choice. So there is definitely abuse potential with buprenorphine. And just some of the formulations, Suboxone you've heard of, it's a sublingual tablet. It also comes as a film. These are all the preparations, and I'm not going to spend a lot of time on that. Subutex is buprenorphine alone. Suboxone adds naloxone to it. And the idea there was the buprenorphine alone can be dissolved and injected. But by adding the naloxone, if you inject it, you inject both the buprenorphine and the naloxone, and it should negate the effect. Although the naloxone is not well absorbed if you use it sublingually. So essentially, if you use it as you're intended, it doesn't have any significant effect. The mono product, as it's called, really, the only real indication for that is during pregnancy. There's no proven evidence that naloxone has any harm in pregnancy, but just an overall philosophy of limiting the drugs the fetus is exposed to. But this also carries the risk, like I said, of people dissolving it and injecting it. And interestingly, a Suboxone tablet will sell for about $20 in the community, whereas a Subutex tablet will sell for about $60. Yeah.
Sorry, just some clarification. You're talking about it not hurting the fetus in utero, correct? Not once.
There's no evidence that, yeah, I think it's a category C.
Okay, yeah, but after birth, I mean, we know that causes issues.
I'm sorry?
After the baby's born, we know it causes issues in a newborn baby with NAS, withdrawal. I mean,
You mean naloxone?
no.
Or buprenorphine?
Suboxone, both of those, yeah.
Well, it is, like I said, it's an opiate.
Yeah. I
It's,
was just making sure there's clarification that it's not a benign thing for babies.
it's not a benign thing for anybody.
Okay.
You guys probably don't remember Talwin, pentazocine. Freshta does. I'm trying to think of other partial agonists. Stadol, butorphanol is used in OB. That's another partial agonist. The idea of partial agonists, they've been around for a while. And in fact, Talwin, the FDA required it be combined with naloxone for the very same reason. People were injecting Talwin. And there's another sublingual form. The film's another tablet. There's now a patch that you put on the inside of your cheek. There's now an implant. These are little plastic rods that are inserted under the skin. Some of you may remember Norplant. Anybody? Beth probably does, and Freshta does. This is exactly the same delivery mechanism as Norplant. That was a contraceptive that had, 5 years worth of progesterone in it. These only hold 6 months worth of buprenorphine, and they deliver it at a rate that is equivalent to 8 milligrams a day of buprenorphine. And most patients that are taking buprenorphine are closer to 16 milligrams a day. So someone has to be weaned down to that for this to be appropriate. And the real issue is that it costs $5,000. And that doesn't cover your cost for inserting it and then taking it out 6 months later. So it's not really clear who that's going to be used by. That's how you insert it. It's just like Norplant, a great big needle. You insert it under the skin, you put the rod in, and then you withdraw the needle and leave the rod underneath the skin. There is now also a month controlled release IM injection of buprenorphine that will supply drug for 4 weeks. And that just became available in November. Interesting study, 2016, comparing methadone and buprenorphine. Methadone has a little better retention in treatment after a year than buprenorphine. That's probably because this is a pure agonist and this is a partial agonist. But look at those numbers. The idea of lifetime opiate substitution therapy has to be compared to the fact that at the end of a year, less than 1 in 5 are still receiving opiate substitution therapy. Opiate abuse-free weeks is about the same, and the cost, yearly cost, is about the same. Okay, the third drug I wanted to talk about is naltrexone. It originally was marketed in 1984 as treatment for people recovering from opiate dependence. It blocks the effects. If you give it while there's an opiate on board, just like buprenorphine, it'll trigger withdrawal. And the idea was that if you were recovering from an opiate addiction, should you relapse and you're taking naltrexone, you'd get no effect from it at all. The problem with it is that there's poor compliance. And this is a busy slide, but what this shows you at the beginning, the first prescription that people fill 1 month later, only 40% of the people refill it a month later. So people stop taking it. And interestingly, this shows naltrexone and disulfiram, and virtually the same thing is true of antabuse too. People will start on it, but they don't stay on it long. So as a result of that, we now have Vivitrol, which is a monthly injection of naltrexone. It was, ironically, was approved for alcohol use in 2006, 4 years before it gained the indication for opiate use disorder. Cost is an issue now, and this is a slide I made up a while ago because that's up to about $1,400 per injection now. Although TennCare does cover it with a $3 copay, which. But the trick with this is that you have to also be opiate free before you start it, and most people will give a test dose of oral naltrexone to make sure they're not going to precipitate withdrawal, because once you put a month's worth in, you're stuck with it. I guess amputation could stop it. But. Okay, now this is a really interesting study that came out almost exactly a year ago. Mortality risk during and after opiate substitution treatment, a review and meta-analysis. They looked at 21 studies from the 70s up to 2016. And of course, these were all methadone studies early on. They came from all over the world. Total in was 138,000 patients, most of whom were methadone patients, but there also was a collection of buprenorphine. Again, because these studies didn't start until after 2000. And this is all-cause mortality. The unit is deaths per 1,000 person years. And this is during opiate substitution treatment. This is during the first month after you stop it. And this is what it finally settles out to be. And this is presumably the mortality rate for someone who is an active illicit opiate addict. And the thing I want you to see here is if this is the mortality rate with a practicing opiate addict, while you're being treated with buprenorphine, that drops over 50%. So like I said earlier about mortality, and the similar thing with methadone, it goes from 13 to 6, okay? So like I said with methadone earlier, simply administering these drugs cuts mortality rate in half. And if you think about that, that's big. There aren't many medicines that you prescribe, or that I've ever prescribed, that cuts mortality rate in half. Maybe insulin for a type 1 diabetic, although a lot of type 1 diabetics can survive DKA without insulin. I'm not even sure that platelet inhibitors after an MI have that degree of effect either. The other thing that came out of this study was during the first month after you stop it, the mortality rate shoots up. So during treatment, it's 4.5, but in the first month after stopping it, it goes up to 32. Shoots up 6 times. So stopping these drugs is also an issue as well. The other thing that's interesting is during the first 4 weeks of methadone treatment, the mortality rate is 11. Initiating methadone treatment has a mortality risk with it also. And this was something that was in the objectives, so I'll tell you about it. This is a new slide. Provider Clinical Support System. That's the web page, PCSS Now. You may have heard of PCSSO, opiates, or PCSS-MAT. This was the American Psychiatric Association. I don't remember who did this. They're grant funded, so they're free. They have live webinars, and if you get on their list, they will send you notices of when the live webinars. They're both on opiate use disorder and also on pain management as well, more recently. They archive the webinars so that you can go back and see previous ones if you want. This is all free, and you get CME credits for either doing the live webinar or the archived ones. And they also offer the training, the 8 hours of CME that you would need to have to get the buprenorphine waiver. They also have a network of what they call clinical mentors that you can either chat with online if you have questions or problems, or contact by phone. So if you're interested or get involved in this kind of treatment, this is a really huge source of information and support. Now this is a really interesting study too. This was 2015, a guy by the name of Weiss, and he signed up 306 people that had treatment with buprenorphine naloxone initiated, long-term maintenance. And he followed them for 3.5 years, which is big because it's hard to do follow-ups with this patient population. And in fact, 6 months is the typical outcome you'll see in the literature. So 3.5 years is amazing. And what he found was after 3.5 years, about 30% were still taking Suboxone and were not using illicit opiates. About an equal number had abandoned the medication-assisted treatment and returned to illicit opiate use. And then this was an interesting group. 32% had stopped medication-assisted treatment, but also were not using illicit opiates. They'd stopped the MAT, but had remained abstinent. And I talked with him. He doesn't know a whole lot about this group because the survey they didn't have the questions that you would like to have asked. But this was not a program that encouraged people to get off of buprenorphine. There was no support or treatment going on, but just the natural course of this, sometime during the 3 years, these folks had managed to come off of buprenorphine and have a good outcome. The other heroin use in this group of people, if they'd ever used heroin, that predicted a worse outcome. Psychosocial treatments. Tennessee requires that there be, the federal law requires that you have available psychosocial treatments to go along with the buprenorphine. Tennessee requires that people participate in them. And there's a lot of controversy there. Cochrane Review in 2011 reviewed folks detoxed, and they found that treatments increased attendance and reduced opiate use. But the companion study looking at maintenance said that they really couldn't find that adding psychosocial support to maintenance added any additional benefit. Now this study looked at it in more detail. This was 27 articles that were trying to assess the value of psychosocial treatment in maintenance. The problems with this study was some of them were methadone, some were buprenorphine, some were naltrexone, some they were administering cognitive behavioral therapy, some motivational interviewing, some contingency management, some just general counseling. And then the endpoints were different. Some looked at treatment retention, some drug use, some looked at 12-step attendance. So these were really hard studies, and they could not do a meta-analysis because they were just so different. Some of them found benefits to counseling, some didn't. The conclusion of the authors was that they generally support the efficacy. Now, my issue with this is looking at these studies, what they considered psychosocial interventions ranged from 30-minute sessions every 2 weeks to 1 hour weekly. And this isn't a lot. You know, if you've been involved in traditional abstinence-oriented treatment for addictions, well, the gold standard was 28 days of residential treatment in the 1980s. When insurance stopped paying for that, the standard had become intensive outpatient therapy, which is 3 hours a day, 4 days a week, 12 hours a week of therapy. And the most these studies had was 1 hour a week, less than 10% of that. So this is a very small dose. You know, it's kind of like giving a tiny dose of penicillin for meningitis and saying, well, penicillin doesn't work for meningitis. And actually looking at these, I'm kind of surprised that at that dosing level that you could find any effect for counseling. About the only less intensive counseling you could have is the single session therapy where they just get a smack. And I'm just going to kind of quickly go through this. This is what a traditional comprehensive abstinence-oriented treatment program would include. Detox, not everybody needs that. It would be abstinence-oriented. The mainstay is group therapy, okay? Is more effective than individual therapy. Most programs encourage self-help attendance, AA, NA, and I'll tell you a little bit more of that in a minute. There's education about the disease, both for the patient and for family members. Family are involved in the treatment. They're encouraged to go to the companion groups, Al-Anon and Nar-Anon. They also receive education, and family therapy can be a part of it. There may be individual counseling if someone has a second diagnosis, okay? Nutrition is a part, physical activity. Acupuncture has been shown to help with withdrawal symptoms. And then other adjunctive therapies such as mindfulness, yoga, Tai Chi. And pharmacotherapy, if indicated, and we've talked about most of these here already. And then aftercare, okay, involving both the patient and family, intermittent sessions, group therapy, including 12-step work, monitoring with urine screens, involving employers. And this is a much more comprehensive program than somebody just going to a group session for 1 hour a week. And those kind of programs can produce really impressive results. This was a study that looked at almost 300 physicians from Washington State's physician health program. And they found that at the end of the 5-year treatment, only 25% of them had relapsed. And another study with a larger group, they collected them from 16 physicians' health programs. They found that 81% had no evidence of relapse at the end of 5 years. However, those that relapsed, the majority of them got back into recovery, and at the end of the 5 years, over 90% of these physicians still had a license, were practicing medicine. So these are really good outcomes, and it shows what an intensive, long-duration therapy can achieve. Now, lest you think that physicians are special people, the Nashville Drug Court has similar results as well. This is a program for nonviolent drug offenders. They go from the jail into this residential program. They stay there for several months. Then they move from that to being there during the night and going out and working during the day, and then they move into a halfway house and work. The whole program goes for 2 years. They looked at 1,400 patients, and 87%, and of course this was done by the criminal justice system, so their endpoint was rearrest. But 87% of people were free of rearrest. And that's big too, because the people that went into this program typically had 3, 4, or 5 arrests for drug-related crimes. So this endpoint is big. The cost was about $65 a day, and that was, or I'm sorry, the cost of jail was $65. Of this treatment was $48 a day, okay? So that's how it got funded, because it was cheaper than being in jail. But unfortunately, I'm afraid nobody's going to come up with $50 a day to treat the general population in this kind of a setting. Okay, 12-step groups. Boy, I'm actually getting ahead of myself. That's okay. This is a list of the kind of 12-step programs that are out there. Of course, AA was the first, and I'll tell you a little bit about the history of AA. Narcotics Anonymous came around in the 1950s because a lot of AA groups didn't want drug addicts there. It was kind of like a prestige thing, you know. I mean, alcoholics were better than drug addicts. Although a survey by AA World Services around 1980 found that 40% of AA members, their use had also involved other drugs. And of course, that's almost 30 years ago, and that percentage, my guess now, is probably upwards 70 or 80%. One of the big issues with AA is people criticize it for being religious, okay? And I would say spiritual rather than religious, and if you want, we can talk about the distinction between those two. But the reason for that goes back to this gentleman, Carl Jung, you know, one of the founders of modern psychiatry. And the way he got involved was this whole story starts with a guy by the name of Roland Hazard, who was a bad alcoholic. He came from a rich New England family, and in order to treat his alcoholism, they sent him to Switzerland to go to therapy with Carl Jung, you know. So he went through a course of therapy with Jung. When therapy was over, he promptly relapsed. He went back to Carl Jung and said, "What can I do?" And he was told that by Jung that alcoholics as severe as you are rarely recover, which was great news. But he said, once in a while, we've seen people recover, and it is the result of a fundamental spiritual transformation. So Jung's advice was go back and hang out with spiritual people and hope for the best. Well, and it actually worked for Hazard. There was in the 30s something called Oxford groups that were spiritual organizations. They were trying to model their work after first century Christianity without all the trappings of the modern church, going back to first principles. And one of the principles was service to others, okay, and helping other people that were in distress. So Roland hung out with the Oxford group people and stayed sober. And among his helping others was this guy, Ebby Thatcher, who he also got into Oxford groups, and Ebby stayed sober. Well, Ebby had been an old drinking buddy of this guy, Bill Wilson, who is one of the co-founders of AA. Wilson was a stock analyst, although I don't think they had that term then, but what he would do would be to go out and write reports on companies that he'd bring back to the brokerages so they could decide whether this was a worthwhile stock to invest in. It was a great job because he was out of the office a lot, and that facilitated drinking. And then his drinking really got bad after the stock market crash. And in 1933, he was hospitalized. This was a hospital for alcoholics in New York City. For the first time, he relapsed, and then was hospitalized again at the end of 1934. And at this time, his old buddy, Ebby Thatcher, called him up. And his first assumption was, oh great, Ebby's coming by, we'll have some drinks. But Ebby, in fact, was now sober, having worked with the Oxford groups, and it was trying to tell Bill about what had happened to him. Wilson's initial response was, oh God, he's got religion, and didn't want to hear any more about it. But a couple of months later, he was sick again, had to be hospitalized again. Ebby saw him again. And after this hospitalization, he started going to Oxford groups with Ebby and also got sober, okay? The next part of the story, he'd been about 6 months sober, trying to reestablish his career, went to Akron to participate in a stock buyout of a rubber company. That was in May of 1935. And while he was there, he was tempted to drink. What had kept him sober previously was working with other alcoholics. So he called a minister in town and asked him if he knew of any alcoholics, which has got to be the strangest call this minister ever got. But they pointed him to this gentleman, Bob Smith, and that is not an alias, that's actually his name, who was a surgeon in town, who had had a long-standing drinking problem, was going to Oxford groups, was not able to stay sober. So he went and met with Bob Smith, and Bob Smith got sober as a result of that. Then the two of them in Akron started working with other alcoholics. Most of them came from Smith's hospital. The nurses would like clue them in when they had a bad alcoholic admitted. And that is is considered the beginning of AA. So as they started working with these other people, then they would become a member of the group, and you know, the number of members began to grow. August, later that year, Bill went back to New York City and formed what amounted to the second AA group. So now we have it in Akron and New York City, and before long there was a group in Cleveland, because people from Cleveland had been driving to Akron and they got tired of driving to Akron. So there were basically 3 AA groups at that point. And it wasn't called Alcoholics Anonymous at that point. 4 years later, they wrote the book, entitled it Alcoholics Anonymous, which was an account of their experience. And in the preface, they start and say, we are over 100 alcoholics who have recovered. In fact, it wasn't 100. It was, you know, somewhat less than 100. But nevertheless, that book got published, and the name the title of the book ended up being the title of the groups. Those are the co-founders in the 50s. This is the surgeon, Bob Smith. This is the stock analyst, Bill Wilson. And AA grew. Now, for a long time, it was just those 3 groups. But in 1941, Saturday Evening Post, this guy, Jack Anderson, wrote an article. Now, he was a muckraking reporter. He would go out and like rip the covers off of scams. And that's what he expected to find with Alcoholics Anonymous. But in fact, he was impressed. Nobody was getting rich from it. It was an altruistic endeavor. And so he wrote an article that was a glowing endorsement. Now, you know, this was the day before TV, and these kind of magazines were, you know, what people read. And this led to explosive growth, okay? From the 100 or so people in 1939, in 1971, 311,000 members, 16,000 groups. 1987, that was up to 73,000 groups and 1.5 million members. And the most recent data I could find was 100,000 groups, and it had spread worldwide at that point. This is often read at the beginning of meetings. It is kind of a nice description of what it is. AA is a fellowship of men and women who share their experience, strength, and hope with each other, that they may solve their common problem and help others to recover from alcoholism. The only requirement for membership is a desire to stop drinking. You don't have to be sober, and people sometimes come to meetings drunk. All you have to have is a desire to stop drinking. There are no dues or fees for membership. They do collect contributions to cover coffee. Is not allied with any sect or outside denomination. It's not part of a church. And the primary purpose is to stay sober and help other alcoholics to achieve sobriety. Outcomes, I'm going to skip that one. The best outcome study is this one, Project Match. And this was a prospective randomized study in which patients were randomized to receive either cognitive behavioral therapy, 12-step facilitation, or motivational enhancement therapy. And they were followed for 3 years, and overall, about 30% of the people remained abstinent at 3 years, and they could find no difference between all three of those groups. So the conclusion of this study was that 12-step involvement was equally effective to what were considered the existing therapies at the time. And then they had some subgroups there. So, 12-step groups are a valuable referral resource, particularly for people that don't have any money, don't have insurance, can't go to some kind of a formal counseling. There is evidence that they're effective, inexpensive, and they can, inexpensive, zero. They're widely available. You know, in Johnson City, there's upwards 30 meetings a week. You've got a meeting in Irwin, you've got a meeting in Elizabethton. You know, they're just all over the place. One of the disadvantages is that there's no professional supervision, okay? And there's no guarantee that everybody there is doing well. So you'll hear some strange stuff. One of the common ones is some people claim that if you're taking antidepressants, you're not sober. And antidepressants have virtually zero abuse potential. And currently, the issue is with medication-assisted treatment. People that are on buprenorphine are not welcome in some 12-step groups. But my advice to people is just look around, see who's doing well, and follow them. So what is it, 20 after?
15.
Okay. Well, that's good. I kind of breezed through that. And I also skipped several slides. So is there any of those slides I skipped that caught your attention? Any comments? Debate? Questions? Yes.
The big one is the place in gray. I guess is that the most evidence-based treatment we have regionally currently for opioid use disorder?
Methadone. The gray clinic you're talking about is the methadone clinic, Over Mountain Recovery. Yeah. And of course, that was in the news a whole lot because there was a lot of local resistance to starting that. The common resistance said that we don't want to bring drug addicts into our community, which they were already there. And the ones on methadone are a lot less worrisome. I don't know if you say it's the best. You know, I had some slides back there that compared methadone with buprenorphine. People tend to stay in methadone longer than they do buprenorphine. I think part of that is because it's a pure agonist and not an agonist-antagonist with a limited effect. So I think the subjective effects of methadone are a little more appealing. Methadone truly doesn't block the use of other opiates. So you can be on methadone maintenance and still use other opiates, although it is felt to attenuate the effects. With buprenorphine, you really can't do that. The big advantage I see to buprenorphine is that it's A, hard to overdose on, and B, it prevents the effectiveness should they relapse to other opiates. I've had several people that'll relapse. I just actually one about a month ago went out and bought 30 milligrams of oxycodone, injected it, and got no effect at all, and realized she'd wasted her money. And that's another, I think the lower risk of overdose and the fact that it attenuates the effect of pure agonists, which is part of what lowers its risk for overdose, are two big things in favor of buprenorphine. The cost is about the same because Over Mountain is now charging, I think, $16 or $17 a day. That's pretty pricey. And in the community, you're paying $100 a week for the doctor, but then you also have to go pay for the medication, which is about $5 or $6 a tablet or more. So you're talking about an additional $70 a week for the medication. And then if you do the math, 7 times 17, the cost is about the same. So I think from a medical point of view, in terms of overdose, buprenorphine is a better choice. Cost, it's a wash. Retention and treatment's a little better for methadone. But the truth of the matter is 20% at 1 year isn't great retention. And most of the studies with buprenorphine show that at the end of 6 months, you've only got about 50% of the people still involved in treatment. The other thing, yeah, go ahead.
Well, I had another question. You can finish your thought.
No, go ahead.
Okay. So I guess I have a question about, is the goal for like long term for these people? Because I noticed some of the data that was up there was that if they stay on it, they're about half as likely to have poor outcomes. Was I understanding that?
Half
right?
is like the mortality
The
risk is kind
mortality,
of,
yeah.
yeah.
So is it?
And if
the
they
goal-
stop, that first month is real risky.
Mhm. So is the goal to kind of keep it on them, or is it very individualized to the patient, or are we trying to get them off?
Well, that's why I showed you that one study that at the end of 3 years, people had come off on their own, a third of them, 30%. And I don't know how they did that, but that's sort of the natural history of this treatment. I'm working at Frontier Health now, and it's supported by a Tennessee grant. So it pays for everything. It pays for my services, the counseling, and also the medication. But you have to have no insurance and be close to federal poverty levels to qualify for the grant. Our goal is to get people off, okay? Taper them down to abstinence. Now my concern is that first month after they come off, there's going to be a period there where the mortality jumps up 6 times. So what I'd like to do is transition them from the buprenorphine when their dose gets down to naltrexone. That'll offer some protection. So that's what I'm trying to do. Most of the community providers are not interested in losing customers.
Yeah.
And many of them will just flat out say, we don't taper people down. And they'll cite overdose risk as the reason. So when you say, what is the goal? What I have seen, I started in addiction medicine in '86 at Woodridge over here. And at that point, addiction medicine was abstinence-oriented treatment, and that was it. Methadone maintenance was out there, but it really wasn't mainstream at all. After buprenorphine has come on the scene, I see addiction medicine having gone into 2 camps, the maintenance for life people and the abstinence-oriented people, and there's a lot of hostility between the two. What I'm trying to do is do something in the middle. A gradual taper. I'm looking at somewhere between 6 months and a year, tapering it down to abstinence, switching them to naltrexone. But the truth of the matter is that there's not a lot of literature out there that describes it. There's literature for long-term maintenance, and there's literature about abstinence-oriented treatment. So I'm making it up as I go along. But that's what my goal is. But to say for addiction medicine in general, there are at least 2 different goals. To not use it at all, or to use it forever.
And that mortality risk, did the study indicate what that mortality, was that mortality associated with like overdoses, people going back mostly, or was it?
Yeah, presumably the reason for that first month is that people have lost their tolerance to opiates. And the idea is if they relapse, they'll go back to using their customary dose, but they don't have tolerance now, and they'll unintentionally overdose. What I try to do with people, because that'll happen if somebody just leaves treatment too. I try to tell people, warn people about that. That if you do go out and relapse, you need to be real careful because what you've used before may be fatal. And that's a real interesting question. They also had overdose mortality. Some of the studies included it, so those figures weren't real accurate. But overdoses made up about half of that mortality. So, and this is all cause. But you know, all cause is really the patient-centered outcome. You know, if you die, I guess you really don't, maybe you do, care whether it's an overdose or an accident or you got stabbed trying to buy drug or, you know, whatever it is. So, so about half of this mortality is the result of overdoses. Probably unintentional. But you know, trying to get this data, first of all, there's no way to distinguish between a suicide and an accidental overdose. And a lot of deaths aren't attributed to overdose. Unless you do toxicology, you may not recognize that there was a drug involved, you know. And unless you do toxicology including fentanyl, which the usual screens don't, you may miss that too. And the toxicology will come back 1 or 2 or 3 weeks later after the death certificate is filled out. So if you recognize at that point it's an overdose, you have to, you know, take the active measure of going back and changing the cause of death. So I think a lot of this, I think half of these were attributed to overdose. I think probably a much larger proportion of them were overdoses that just didn't get recorded that way. What I was going to say is that part of the studies that have looked at why physicians like you guys don't incorporate this into practice, and there's a bunch of different reasons. Some of them are just administrative and that kind of thing. But the biggest reason is, quote, you know, I don't want those people in my waiting room. And what folks don't realize, I mean, your guys' exposure to opiate use disorder is the guy arguing with you about how many Lortab he gets. And I know you've all seen that, probably on a weekly basis. And it's a pretty unpleasant encounter. These people that are trying to recover that are on maintenance are much more pleasant people to deal with. They're not trying to scam you out of a prescription. They look healthy, which is one of the cool things to see when I get a new patient that comes in. Over the next 2 or 3 months, just their physical appearance improves. And so these folks are not as difficult to work with as you might imagine. And it can be a real rewarding part of your practice. When you think about it, we don't have that much effect on a lot of the other diseases we treat. You know, congestive heart failure, you can attenuate the symptoms, but you don't cure the disease. You don't arrest it. It's still, you know, progressive. And most of the diseases we treat don't have as dramatic effect as this. Maybe depression. That's another disease where treatment can have a dramatic effect. But what I'm trying to tell you is that these patients are worthwhile to work with, and they're gratifying to work with too. So it's not as bad as you might think. Any other question? You're just scratching your head, aren't you?
I think that was a good thing to talk about. I think we've been unfortunately jaded by the lack of community facilities or prescribers that don't look at abstinence, and that's what many of us feel should probably be a primary goal. And how would we incorporate that, and what would that look like? And if there is a sub-cohort of people who would need long-term maintenance therapy, how would you identify those people? Who would they be? And what's the difference between them and someone else?
And I think they get identified just as you try to wean people off. They're either resistant or it's just not successful. I agree with you. I mean, if you look at the literature, there are a lot of effects, biologic effects of long-term opiate use. Attenuating immune response is one of them. So I just don't think that occupying the opiate receptor on an indefinite basis is as healthy as an abstinence-based outcome. You know, my own treatment was abstinence-based. Of course, as a physician, I wasn't really given a choice on that. But I do think, and I also think that it ends up with better emotional health as well. Because these receptors involve mood, and if they're chronically occupied, it would seem to, follow that moods are going to be altered chronically. So I think abstinence is a better goal. But the truth of the matter is we're in the midst of an opiate epidemic, an overdose epidemic, and a drug that can cut mortality in half. That's a big selling point for it. And it's getting worse now. I was listening to the radio before I came over here. Of course, all of the illicit opiates are likely now to contain fentanyl in unknown doses, but there's also counterfeit oxycodone, hydrocodone that have fentanyl rather than, and I had a patient who's overdosed accidentally twice by taking what he thought was a Lortab, but in fact was a counterfeit Lortab. But now fentanyl is turning up in cocaine and in marijuana. So there are folks that are getting opiate overdoses that had no clue they were taking an opiate. So the overdose risk is, I don't see any signs that it's going to drop anytime soon. Is it time? It is time.
Thank you so much for coming today.
Oh yeah, it's fun. Thank you all for listening.